I'm going to wait for one more minute. I think there's a few more people out in the atrium. Souhaite la grande bienvenue. I'd like to thank you all for being here tonight. My name is Ruth Slack. I'm the director of the Brain and Mind Research Institute. And on behalf of the Brain and Mind team and all our researchers, I'd like to welcome you here tonight. And this week we've had Brain Health Awareness Week, and this is actually our fourth evening where we've had sessions every night. And these are also live streamed on Twitter, on Facebook, and so on. So the session for tonight is negotiating the storms of adolescence, cannabinoids, depression, and self-harm. And one of the pillars of the Brain and Mind Research Institute is mental health. And what we do is we bring together multidisciplinary teams of researchers, so that's basic discovery researchers working with clinical researchers, and we link them from across the city of Ottawa to work together and focus on different research questions. So for example, tonight we have researchers from CHEO, from the Ottawa Hospital, and also the Royal Ottawa Mental Health Centre. And tonight's session will be emceed by Dr. Simon Hatcher. So just to tell you a little bit about Dr. Hatcher, he's a professor of psychiatry at the University of Ottawa. He did his medical training in the UK, and then he moved to Auckland, New Zealand, where he was there, I think, for 10 or 12 years. And he ran a psychiatry service at the University of New Zealand. He is now the Vice Chair of Research in the Department of Psychiatry at the Ottawa Hospital and a member of the University of Ottawa Brain and Mind Research Institute and also the Montfort Research Institute. And Dr. Hatcher's research interests are focused on providing mental health care for people in non-psychiatric settings and using technology to assist mental health care and health services research. And so thank you, Dr. Hatcher, for being here today.
Thanks very much. Good evening. Bonsoir tout le monde. It's really my role here to MC the evening, and you really don't want to listen to me talk, I'll tell you, because basically what Ruth has told you is I've got an impenetrable accent, which just goes all over the place. It varies from Kiwi to British to sometimes Canadian, and at a push I can talk Australian if that helps. You haven't come to hear me. I'm here really to introduce the speakers. The speakers are going to present in this order. We're going to have Gail Beck starting, we're going to have Bill Gardner, and at the end Mario is going to be giving you the answers to the problems posed by the first two speakers. So that's what he told me just now. I'd like to introduce Gail first, Dr. Gail Beck. Dr. Gail Beck's a child psychiatrist. She's a writer and a speaker. And she was telling me just before we started that she's got a book proposal in process looking at cannabis in youth. So that's I knew of her interest in this area. It's one of the reasons why I asked her to speak. She's the director of the youth program at the Royal Ottawa, and clearly has a major interest in this area. And it's my pleasure to introduce Gail. And one other thing as well to mention is she does have a blog. It's drgailbeck.com. Yep. If you want to follow her, you can follow her blog as well. But don't do it now. Pay attention to her. Okay. Gail.
Thank you. What I will say is that honestly, if you're going to follow my blog, follow it whenever you want. I'm just going to move over so I get a look at my slides. It is a great pleasure to be here this evening And I haven't brought a lot of slides because really what I want to do is to leave time for some of your questions. One of the reasons that I did decide to write a book about this is that I've had a lot of attention since cannabis became legal in Canada in 2017. And I think that one of the reasons for that is that we know Canadian youth are the highest users of cannabis in the world. And that's a very worrisome thing, and we don't necessarily know the reason for that. I'm just going to, oh, I've done something wrong. Okay.
Just going that way.
Great. So I just wanted to talk a little bit about the risks of cannabis use in youth and in young adults. Just, I'm going to talk about some of the more urgent things related to intoxication and the underpinnings of a public health approach to cannabis and why I think that that's important. But I'm not going to inundate you with slides. I have no financial interests in the cannabis industry. So for those of us who work with young people in mental health, we have three concerns regarding cannabis. We are concerned about its impact on brain development. There is a positive correlation between cannabis use and the onset of mental illness. And then there are particular risks with respect to youth who are driving under the influence of cannabis. So this is the developing brain information. All of this is very well established. We know that the brain develops sometime in the mid-20s. And it's not the kind of thing where you can say at this age your brain is developed. It's more of a continuum, but we know it does take till the mid-20s for the brain to develop, and that's important. The use of cannabis, anybody who takes cannabis will have symptoms of impaired concentration, diminished cognitive functioning, and especially in the areas of problem solving and executive functioning. What you find is that in a fully developed brain, even for somebody who's used cannabis for a long time, those impacts will reverse. But in a developing brain, they may not, in fact, reverse. And because of these, you can see a long-term difference in this person's ability to solve problems and in their executive functioning. And so this can affect academic performance. And some studies are measuring as an IQ change of as high as 10 points, which is significant over a long period of time. To give you an idea of the extent to which we deal with this in our clinic, and I'll acknowledge that at the Royal and at CHIO, because we have a partnership, the Young Minds Partnership, to look after the most serious mental health problems in the region. As we triage cases, Monday afternoon I sat down to triage cases. We triaged 10 cases to see how we were going to distribute them among the members of the youth program at the Royal for assessment. There were 7 of those youth who were using cannabis on a daily basis in excess of 3 grams. And there were none of them who had not tried cannabis. So that gives you an idea of the extent that we're looking at it, considering that what we're doing is that we're concerned about the impact on mental health. So if you talk to any young person who's using cannabis, they'll often tell you that the main thing that it does is it helps them with their anxiety. And when in fact, the evidence is actually the opposite. You see both an increase in anxiety and depression because of cannabis's effect on the serotonergic system. We believe that when they say it helps their anxiety, that because of the extent of the use that we're seeing, perhaps we're actually looking at someone who is already addicted to cannabis, and you can become addicted to cannabis. There's a lot of people seem to say that you can't, but we know this is not the case. The other symptom that we see is that there's in youth with a genetic predisposition, so a first-degree relative, a mother, a father, a sister, a brother, or even a more remote relative with schizophrenia, you do see an earlier onset of that illness if they're already genetically predisposed. In addition, there is a subset of psychosis called drug-induced psychosis. And so you can see youth who've used cannabis who develop a drug-induced psychosis. Unfortunately, you treat that condition exactly the same way as you treat a schizophreniform psychosis or a bipolar mania with the same medications, and you hope that if it's drug-induced, that it will resolve with a year or so of treatment. But once you have those symptoms, it may be that you have that psychotic illness for life. Finally, speaking to the more acute condition, you can see paranoia and brief psychotic disorders that are secondary to a toxic dose-related intoxication of cannabis. This was the other slide I really wanted to talk about a little bit today, because these are brand new findings. And I looked at this data on Monday. It may be different now. Both Health Canada and the Centers for Disease Control in the United States are tracking cases in which vaping has caused lung injury. And of those 805 cases, there have been 12 deaths. In Canada, they haven't tracked case numbers yet. They're counting them, is what I've been told. We have one death in Quebec related to vaping, and there is another young person who's seriously ill in London, Ontario, and on life support. For the 805 cases in the United States, there is age and sex data on 771 cases, and I wanted to show that difficulty in youth. You can see that 62% of these young people are between 18 and 34. I hope the person with the baby didn't take them out of the room. I grew up in Quebec, and in Quebec we think it's good luck to have the sound of a baby in the room. So if this talk starts to go really bad, you'll all know why I think that happened. And finally, 22% of those youth in the United States are between 18 and 21. Now, as compared with Canada, in general, the age at which you can start to use cannabis is 19 or less. A few provinces have that at 18. In the United States, cannabis is legal in 33 jurisdictions, and for the most part, they've kept the age of use, I believe, at 21. I was trying to do research on that for this talk to see if that, how many states had lower age of use. But there were a lot of states, Colorado, and some of the states that have the most publicized data have a legal age of 21. And to me, the implications of that are how many young people are using cannabis at an age when it's still illegal for them. The other thing is 504 cases, 77% of them are vaping tetrahydrocannabinol, which is the psychoactive ingredient in cannabis. And so that's very worrying. And the Centers for Disease Control has gone so far as to say that there may be a link between cannabis and vaping cannabis and lung injury. And they are warning people to be cautious when they're doing this. Those are the bits of information. I just wanted to talk a little bit about public health campaign, and I wasn't going to put a slide together to talk about that. We had a side conversation about vaping in general and about and one of the big things that comes out of that is that recently Health Canada has said that you have to stop marketing vaping products that are flavored because they appeal to children. And we really have a need in this country for a sophisticated public health marketing campaign that can provide accurate, very good information to parents and that can actually engage youth in a public health campaign about the risks of cannabis. You might think from this talk that I don't support legal cannabis. In fact, I do support legal cannabis For me, legal cannabis is regulated cannabis, and we know that regulating other substances like alcohol has helped to keep them out of the hands of people who should not be using them. And so I do think that regulation may help us. The other way that I think regulation may help us is that very often we'll see a young person who is intoxicated, and they'll say to us that they've used cannabis, and we'll do a urine drug screen. And when we get that urine drug screen back, it's not positive for only cannabis. It's often positive for opiates, and occasionally even for other substances. The fact is that if you are, by and large, 18 years old and buying cannabis, unless somebody older than you is buying it for you, you're buying it from a dealer. And so the chances of that being as pure as the legal cannabis shops has to make it is just not the same as if you're buying it from a dealer on the street. And so from our perspective, we are as worried about what cannabis is being cut with as we are sometimes about the product itself. Particularly because one of the more easy things to cut it with is fentanyl, which is highly, has a lot of problems on its own and is in fact dangerous. So we know that the Government of Ontario, Government of Canada are capable of really sophisticated campaigns. And so I don't know why they haven't undertaken to deal with this, with the truth about marijuana in the way that they've dealt with the truth about cigarettes, the truth about drunk driving, these kinds of things. And unfortunately right now, it's a bit of, if you look at all the cannabis ads that are out there, every week in the National Post and all of Postmedia's papers, you'll get a section of the paper that's called the Cannabis Post. And it is entirely produced by the cannabis industry. It's information on cannabis. Governments don't have deep pockets. They can compete to some degree in public health education, but they're not going to compete with that kind of thing. So the other thing I'd really like people to think about is the need for very solid, sophisticated public health messaging with respect to cannabis. I want to thank you again for coming this evening and listening to me. I'm certainly happy to address your questions. Merci beaucoup d'avoir venu. Chimigwich.
Okay, thank you, Gail. The way this is going to work is we'll have the speakers present first. And then you can take questions afterwards, or you can vote them off, or we can do some sort of reality TV thing, however you want to do it. But we'll start with questions. So the next speaker is Bill Gardner. He is a senior research chair in child and adolescent psychiatry at CHIO. He's also an epidemiologist. And if you happen to be American, he's a significant contributor to the blog The Incidental Economist, which is all about health policy in America. I was quite surprised to actually have a health policy in America, but there you go. Dr. Gardner.
Thank you, Simon. So I'm going to talk about self-harm in Ontario adolescents and a few other issues along the way. Let me just first get some acknowledgements done. I have many collaborators on the data and the research I'm going to present, including Dr. Hatcher and Dr. Capelli. My research is funded by Scotiabank, the Public Health Agency of Canada, the Canadian Institutes for Health Research, and the U.S. Centers for Disease Control. But if you are a funder, don't let all that generosity other people have shown get in the way of contributing to our work. Just want to be clear about that. I don't have any commercial interest in anything. I'm going to be presenting some stuff that's been recently published in the Canadian Journal of Psychiatry, but also stuff that's coming out soon in the Canadian Medical Association Journal. That's still under embargo, so if by any chance somebody here is from the press, please talk to me about anything you want to quote, because some of it you'll have to wait, but I'd be very, very happy to work with you on anything you'd like to say. So, what am I going to talk about? I'm interested in using the emergency department as a sort of window on the population health of Ontario children. And I'm going to look at health outcomes, is our first question, of adolescents who present to emergency departments with self-harm. And after talking about, that issue and the degree to which, and what the health consequences for those kids are, I'm then going to, okay, apparently I'm doing this wrong. Okay, great. I'm going to talk about the trends in the use of the emergency department for self-harm. And then I want to just say a few things about the implications for clinical care and adolescent population health. So, real simple background to this. There are many behavioral and mental health problems that affect teens, including self-harm, mental health disorders, and substance misuse. Now, for those kids, and perhaps this is unfortunate, but it is a fact of life, the emergency department is a critical point for entry to care. So, what do we know about ED visits by adolescents? I'm interested in kids here at ages 13 to 17. And there are about 850,000 such kids in the Ontario population in any given year. In a typical year, about 190,000 of those kids will visit the emergency department. That rate has gone up slowly over the years. But I'm giving you these numbers to give you the sense of what we're working with big data here. And we're really trying to look at all the data for an entire population. And I think that's a great advantage. And I hope I will be able to make that clear. So the first question I want to ask is just, okay, a kid shows up in the emergency department and he or she has poisoned him or herself or cut themselves or something like that. How significant a problem is that? Is that something we really need to, of course we'll worry about that, but how much? So we've done a study where we look at 5-year health outcomes for kids who have those self-harm visits. And we did it by looking at all the kids who showed up for all Ontario emergency departments from 2011 to 2013. There are 400,000 plus such kids. Of these, 5,800, it's about 1.5%, had a visit for self-harm. So in terms of the total business done by the emergency department, it's not huge, but still, 5,800 kids is a lot of kids. Now, we were able to match 5,600 of those with a greater number of other kids who had emergency department visits, very closely on demographic factors and a whole range of clinical things, including mental health variables. And so what we're doing is that we're looking at kids who had an emergency department visit for self-harm and other kids matched to them who are very, very similar. We used to have about 35 variables, except that they didn't have that visit. And so that's some way of getting a sense of how much difference, how different is it going forward from that, given that you had that visit. And this is, it's not perfect, it's not a substitute for an experiment, but of course you can't randomly assign people to having self-harm. So, what happened to them in the next 5 years after they visited the emergency department? Well, we compared those two groups of adolescents on deaths due to any cause, suicides, subsequent visits to the emergency department or hospitalizations for self-harm, and an estimate of what it cost to care for their health over those 5 years. And I've got to qualify that, but I'll wait till I get to the relevant slide. So let's look at the results. These are the data for the deaths of any cause. And what you see is that the two bars are the group that had self-harm and the matched group that did not have self-harm. And then the vertical axis is deaths per 1,000 kids in these subgroups. Okay? And so you can see there were 10 per 1,000 among the self-harm, and about 3 among the group without self-harm. Basically, deaths from any cause were more than 3 times as likely among the self-harm group. Suicides. Again, graph is set up the same way, and you can see that the difference between these two groups in terms of suicides is very stark. In fact, suicides were 8 times more likely among the kids who had a self-harm visit than the matched group. However, keep in mind in thinking about this that we're only looking at 8 suicides per 1,000 kids. So it's not a high, a super common outcome even within the self-harm group. Then that poses the question, does having a self-harm visit to the emergency department predict that a kid is going to die by suicide? Well, we can say that having such a visit gives you a very high relative risk, even compared to very closely matched kids. But even if you have a self-harm visit, you only have a 1% chance of suicide during the next 5 years. So it's not a super common outcome, even though these kids are at very high relative risk. It's a really hard thing to try to keep these things both in mind at the same time. I think the clinical implication is if a kid shows up in your emergency department and they've self-injured or self-harmed, it's not necessarily from that fact itself something to, turn on the flashing light and run the siren, but it certainly is a very strong reason to do a suicide risk assessment for that kid. Now, there's a lot of people may have different opinions. I'd be happy to talk about it. So what about self-harm readmissions? Now here, the important thing to know is that the vertical axis is now percentage. So this is cases per 100. And therefore, almost 30% of the kids who showed up in the emergency department with a self-harm visit will have another such visit within 5 years. So this is a group that is a relatively high user of emergency services relative to the kids who did not have self-harm. In fact, these readmissions were more than 4 times as likely among the self-harm group. And finally, medical costs over 5 years. What we did is that we looked through the big database of all health services that kids have held by the ICES and we summed up all those estimated costs. The thing is, we don't capture all the costs for outpatient medical drugs, and we don't capture mental health services given by non-psychiatrists by and large. So that these are underestimates, bottom line, sort of lower bound estimates, as you like, of what you'll spend on these kids' costs in healthcare. Nevertheless, we see that youths with a self-harm ED visit cost more than $11,000 more per kid over 5 years. Now, that's a significant sum of money, and if you think that there was 5,600 such kids, it comes to about $64 million additional costs for this subpopulation. Now, I don't have a magic wand for an intervention that would reduce those healthcare costs, but it does say that if we did feel like there was some way we could intervene early to help these kids after we pick them up in the emergency department, there's a lot of fiscal space there that we could possibly get resources that might pay for itself to some degree. So is self-harm a serious problem? I think it's clear that it is. Compared to youth who are carefully matched to other youth, the self-harm kids, it was a marker for substantially increased risks of mortality, including suicide. 3 in 10 youths with self-harm visits will have a readmission within 5 years, and they account for $64 million additional dollars of healthcare cost. So this is a population it's a problem that needs to be taken seriously. So what's happening with this? Is self-harm getting better or getting worse for adolescents in the province? Well, we can't say I don't have a way to say for the whole province because I can't go out and talk to kids, household by household. But I can tell you what's happening in the emergency department. What we did was we looked at all ED visits for adolescents from 2003 to 2017, more than 2 million visits. We classified visits as having self-harm and we also looked at whether they had a mental health disorder using diagnostic codes. And for each year, we looked at the rate of visits per 1,000 kids in the population. So here's what the trend looks like for self-harm. This is kind of an interesting trend. First thing to say about it is that it clearly bottoms, there's this low point in 2009, but since then, rates of use with emergency department visits for self-harm have more than doubled. And if you look at the data from 2009 going forward to 2017, there is no sign whatsoever that the increase is slowing down. It's rising in a very tight, linear way. In fact, this is, if you're not a statistics aficionado, this might not mean too much to you, but R-squared is a measure of how close the lines there fit the data. An R-squared of 1 is perfect fit. This is an unbelievably close fit for social science or epidemiological data. The other interesting thing is that it was going down quite steadily from 2003 to 2009. And this is going to prompt a question in all of your minds. We'll get to it in a sec. Now let's look at mental health visits. And again, you can see that there's been a very large increase since 2009. The bottom line there is not 0, so perhaps it looks bigger than it is. But really the key thing to know is that the rates of youths with ED visits for mental health disorders have nearly doubled since 2009. And again, the data fit really remarkably closely, and they're still rising as of our last data point in a quite steep way. So you all are asking me now, what happened in 2009? And the answer is I don't know either, but let me speculate. The first is that that was the time when the Great Recession hit. Now, of course, and the bottom fell out of employment in the province. Employment has improved a lot since then, but it hasn't improved for everybody. And maybe there are subpopulations that remain in substantial economic stress in which we're seeing accumulating problems. That's a possibility. The second is that there were large-scale destigmatization efforts for mental health across the province starting at about that time. Bell Let's Talk starts about then. And it might be that families and even to some degree adolescents have been more likely to seek care in the emergency department as a result of these efforts, which would be a good thing. But it means that there are a lot more kids showing up. And it's possible that doctors are more, the emergency physicians are more likely to find mental health problems as a result of destigmatization efforts. But the one that the kids talk to me about, because I do focus groups with kids who have gone through our mental health program, I remember the first time I talked to this young girl about this, and she looked at me as if I was the stupidest person in the world, and says, duh, smartphones. Well, I think that the social media and the iPhone have really transformed the experience of being adolescents, and it hasn't gotten easier for a lot of them. Okay. I want to just point something out here. This is work we're doing right now on cannabis ED visits. The blue line is kids who visit the ED are age 10 to 13. The red line is youth 14 to 18. And the green line is young adults 19 to 24. And what we're looking at here are emergency department visits for cannabis intoxication, right? When I was a kid, I had no idea that was possible to that degree, but I think what we're seeing in part is these really intense THC preparations that Gail was talking about. Grâce à Dieu, they haven't increased very much in the youngest kids. But what you're seeing in the 14 to 24 year old group is that these ED visits have nearly quadrupled. And the trend lines there are actually cubic trends. It's a very simple function, meaning that things are increasing as a function of the number of years cubed as time goes along. That's a really fast rate of increase, and again, there's no sign that it's slowing down. And again, the data fit, these models fit very closely. So I'm getting to I'll be done in a sec. What are the implications of all this? Well, let's first of all think about adolescence and health policy. The overall summary is that rates of emergency department visits for self-harm, mental health, and substance use, there are more substance abuse data I haven't shown here, have been increasing, and they've been increasing rapidly. There have not been commensurate increases in treatment resources. Then this causes great stress for pediatric emergency medicine and for mental health care, right? It's only a few thousand additional kids, but I'm showing you that in some cases, the rates of cases coming to the emergency department has doubled, tripled, or quadrupled. That really, really has a huge effect on the number of cases that psychiatrists in hospitals, like in CHIO, have to handle. And it's just an immense strain on the quality of care for everybody. But also, we're seeing these very clear social trends across the entire population of the province. We need to understand what the underlying social dynamics of these epidemics really are. So then the question, should we be saying that youth in Ontario are in crisis? Well, there is a cluster of ED visit types for serious health problems that reflect significant behavioral and perhaps mental health dysfunction, and they've been increasing dramatically. However, increases in those ED visits don't necessarily apply that the typical adolescent teenager is in trouble. Right? I mean, most of the kids could be doing just fine, and I think probably are. but there could be a subgroup that's doing really badly. Kids who are vulnerable or at risk for various social reasons, or for their exposure to abuse or something like that, that have really been suffering recently. And if these problems are concentrated in a small, vulnerable subset, that group is in significant trouble. So we could be seeing an increasing divergence in the mental health and behavioral outcomes of kids in the province. So what's the next steps for our research? We're interested in other signals of adolescent population health that we can study. We want to know how these problems vary across geographic areas and demographic subgroups. And we generally want to know how we can use health services data to better identify kids in trouble. We're working with big data here. This is a province rich in machine learning and artificial intelligence skills. We could be applying these things to the very large, rich data sets we have to get better tools for finding out who really needs help. And I'll finish here with just mentioning that there's a overall large opportunity for the province here. I hope I've made the case that administrative health data can provide a deep look into population health. In Ottawa, we have the ability to access population health data on birth outcomes, newborn risks, lifespan health services data. These linked data sets provide fantastic information about the health trajectories of Ontario's children. We should be trying to put them to work to find out what we need to do to raise the population mental health of kids in the province. Because better health policy now would result in healthier and more capable adults in the next generation. Thank you. And if you want to know anything more about me, I can be contacted at CHIO, or you can reach me on Twitter. Thank you. Oh, you want this back?
I was going to load it. Thank you.
So here we go. So thank you, Bill. It now gives me pleasure to introduce Mario Capelli. Mario is a senior scientist and the at the Ontario Centre of Excellence for Child and Youth Mental Health. He's a psychologist. He does clinical work and research. And what he's going to do is to tell you about, well, what happens when adolescents turn up in ED, and how do we manage that problem. So Mario, who hopefully has found a pointer and his slides.
Oh, great. We're gonna,
There we go.
I want to toggle back and just go, and then go back and forth. Okay, great. Thank you. So thank you as well for making it out tonight at rush hour, which is never easy. And it just seems that this whole city is under construction, and it took me half an hour to get from basically the civic site to here. And so thanks again, and I notice our time. Thank you to the speakers. This is supposed to end at about 7:30, I think, right? So I have an hour and 15 minutes, so I appreciate you guys talking quickly. You know, it was really interesting listening to Gail and to Bill, because I think some of the takeaway messages from them is that there's lots of kids that are really struggling with their mental health and presenting to lots of different places with their concerns. My interest is I'm a health service researcher. And I'm really interested in how do we bridge the kids' needs to services in our community, and how do we help the folks that are responsible for navigating those services to be able to connect the right needs with the right services. And what I'm going to talk a little bit about today is how we help our physician colleagues in the emergency departments, as well as our colleagues in family practices and family health teams, as well as others, in terms of being able to bridge, the services valley there. And the other thing I just want to mention before I get started is that this work does take a long time. And in fact, the work I'll talk about tonight has been about 10 years in the making. So even though it's, I'll have 15 or 20 minutes to talk about it, it really reflects nearly a decade of work that I've been involved with, along with a whole bunch of my colleagues. I'm currently on, my permanent home is CHEO, where I'm the Director of Psychiatric and Mental Health Research, but I'm actually on a secondment right now to the Ontario Centre of Excellence for Child and Youth Mental Health as their senior clinician scientist. So I too want to acknowledge a number of funders that have contributed to the work that we're doing, including the Brain and Mind Institute that has recently provided some support. I personally don't benefit financially from this, which is unfortunate because my neighbors drive nice cars and I don't. I also want to acknowledge the fact that, even though I always think of myself as the spokesperson for a real huge group of folks that have been working on this, including fellow psychologists and physicians and colleagues, but also a whole bunch of students that contributed many, many hours to this work. So I'll talk a little bit about this tool that we call the HEADS-ED screening tool, and I'll walk you through that and show you how we help, how that tool helps clinicians to assess mental health risk, how it helps them to make clinical decisions, and finally how it helps them guide the levels of care. And then I also want to talk a little bit about how the tool, which was originally developed in the Emerge department, moved to the community. I should say that my own work in the Emerge department, really began nearly 30 years ago when I first started my first job as CHEO, and I was working on the inpatient unit there, and I had a friend of mine working in Emerge, and I'd go down in the emergency department, and the place was a disaster, right? And and these guys had nothing to do, didn't really understand how to deal with kids presenting with mental health problems. And I said, at one point, I'm going to come back and do some research here. And it took about 20 years before I finally got back. And I think, the timing was interesting because it was during that time that things started to happen, that we're starting to see this huge increase in mental health presentations to the Emerge. We've all seen this stuff, right? Headlines like this is the one from the New York Times where American teens are suffering more than ever from severe depression. The Toronto Star talking a bit about how half of Ontario youths miss school because of anxiety. The figure showing that the increase in depression in the U.S. and similarly in Canada going from about 5.9 to 8.2%. But it's not only in the papers. This is do we have a pointer by any chance? Oh, is this it right here? And the pointer is so that I don't want to... Right there? Awesome. Thank you. So essentially, this is a study that's done every 2 years in Ontario, and it's run through the folks in Toronto at CAMH. And what they do is they survey our youth and children in schools between the grades of 7 to 9, and they ask them a whole bunch of questions regarding their emotions, their behaviors, their substance use. In this particular one, what they're looking at is they ask the kids, how often do you experience these things? Most of the time or all of the time. And so when they ask girls, about 28% of girls report feeling, pretty nervous most of the time or all of the time. Feeling restless and fidgety and feeling that everything's an effort and feeling really depressed and feeling worthless and feeling helpless. These are pretty astronomical numbers, and these are surveys from 2 years ago. And you can see the yellow are the boys, and similarly, they also, high rates of concerns that they're reporting. If you look at our ED visits, and I know Bill's already talked a little bit about it, and this is the most recent information or data that was just presented by the folks at CIHI, and you can see that since 2006 to last year, the rates of kids presented to the emergency departments increased 75%. The number of kids that were admitting for mental health reasons to hospitals is increased 65%, and interestingly enough, the number of kids that were admitting to hospitals for physical reasons has actually decreased by 24%. The line that's missing here is that if you take a look at the percentage of kids who present to our emergency departments for physical reasons, hasn't changed in the last 10 years. So there's been no change there. So that line there is missing. So what do we know? We know that in general, kids are presenting, with lots of different concerns. And where do they present? Where do most people tell you to go to? They go to the emerge department. So the question is then, great, so they come to the emerge, and we have a bunch of physicians there that are really, caring, and nurses that are caring, but they have no real idea how to manage those kids. There's no tools out there that helps them to guide their assessments. We know that only about 9 or 10% of VD physicians use any evidence in terms of guiding their decision making. And even though we know these are the American, professional associations, but it'd be the same in Canada, that are all recommending that we should be developing clinical tools that would help, physicians to detect mental illnesses. But, we don't have any. So the first question is, can we actually develop a screening tool? And so off to the races we went. If you're going to develop a tool, if you're going to try to, use any kind of a method to help, manage kids who present with mental health problems, you really have to be able to do 3 things. First, you have to be able to assess the actual level of risk, like how severe is the problem? Like, you got to be able to triage. Is this a mild problem, moderate problem, a severe problem? So great. Now that you know that, the next question is, well, what do I do? Right? How do I manage this risk? And then after that, what is the next level of care that the child or youth should be able to access? So if you're going to develop a screening tool, and it has to be able to do all 3 things, it's a pretty big ask, because I'm not sure about what it's like when you go see your family physician. I'm not sure if you've been to an emergency department lately, or if you brought your child to an emergency department, because if you ask most emergency physicians or most docs, the real important things that they look for, and if we're going to develop something for them, it better meet these criteria. It's got to be really, really brief, right? It's got to be really easy to score. It's got to make clinical sense. It has to be valid and reliable. It has to help their guide decision making, and it has to help them in terms of guiding their treatment recommendation. The tool has to be done within 3 to 5 minutes. So basically, that's how much time they have until they move on to the next patient, or they have to move on to the next thing. So they're not going to be able to spend, if they come to see me or they come to see Gail or Simon, they're not going to be able to spend an hour talking a bit about, the problem. So the tool has to be able to do those 3 things in a really, really quick way. I'm not that smart to be able to develop a tool like that. So what we did was that we actually went back to the literature and said, what actually exists? And there were 2 things that were out there that we thought we could draw from. I'm not sure, I may be dating myself. Do you guys remember, what was that? Trying to think of that. It was a chocolate, and it was the Nestle's, the chocolate, the one where there's the commercial the guy has, he was walking, he bumps into the other person, and oh, you got chocolate in my peanut butter. Remember that one? You got peanut butter in my chocolate. And you put the 2 together, they tasted so much better. That's the peanut butter cup, right? That's what we kind of did. Is we took 2 things that were already out there, and we said, can we blend these 2 things to bring them into one particular tool? So the first thing is this thing called the HEADS. So the HEADS was originally published in 1991 by a group of researchers in the U.S., and it was developed to help physicians be able to ask youth different questions. So H stood for home and education, and activities, and so on. The second thing was this measure called the CANS. It was developed by this researcher in the U.S., John Lyons, who actually spent some time here in Ottawa. And what he did is develop a tool where he would ask a question, and depending on the answer of the question would help determine whether or not you needed to act on that either right away, or if you could wait a little bit, or maybe it just really wasn't that big of a problem, so you didn't have to worry about it at all. So we said, can we take the heads kind of things, can we take this way of thinking and put it together? And so that's what we did. So the first thing is that the heads, is that me? No. Okay, that's up on the top row. Doesn't sound like a baby. Feels like that Star Trek episode. Okay, thank you. So the heads basically stands for, the H stands for home. It's a mnemonic. So the H stands for home, E is for education, A is for activities, D is for drugs and alcohol, S is for suicidality, E is for emotions, disturbances, and thought, behaviors and thought disturbances, and D is for discharge resources. What's available when you discharge them? And so you basically, the patient shows up, the physician would ask, how are things at home? Right? And if the home was supportive, they would just tick supportive, right? If there was conflicts, they would tick conflicts. How are things at home? Well, we argue a lot. Okay, that sounds like a 1. How are things at home? Well, he ran away, there's been lots of fighting, so things are pretty chaotic, so they would just check off a 2. And similarly, it'd be the same thing for education, for activities, for drugs and alcohol, for suicidality, for emotions, behaviors, and thought, and whether or not they already have any services that they're connected to or whether they're waiting. Pretty simple stuff, right? Because again, we're dealing with physicians, and physicians don't have a lot of time. And if they have to go to a manual and read things, they're not going to do this. So we have to make it as simple as possible for them. But it still has to really guide and be effective in terms of determining the risk. So, the question was, now that we have this tool, can it actually do those things that we wanted it, or we claimed that it might be able to do? So, the first thing is the level of risk. So I'll walk through a couple studies. So this was a study that we did in our emergency department, and we published it a few years ago. And so we had our emergency crisis worker. If you come to CHEO, most days between the hours of approximately 8 to 11, with the exception of weekends, we have 1, sometimes 2 crisis workers that are for mental health that the child would automatically see. So the mental health crisis worker, that is usually a master's in social work, a clinical social worker would do the heads ED. So basically ask these kids these questions and tick them off. She also got the children to complete the children's depression inventory, which is a measure of depression. And finally, the crisis worker also completed the CANS. Remember I talked about the CANS, which stands, the CANS takes an hour to do. So if you're going to do the CANS, it's a pretty detailed, assessment. So the first thing I want to show you, how many folks here understand statistics? Anyone? We got one? One statistician? See, Bill, all those stats that you showed them, and so these statistics are basically correlation coefficients. So basically the correlation is how well does one variable correlate with the other. As one increases, the other increases. One goes down, does the other go down. All you need to know is the stars. So basically, the stars are good. Basically says that the more stars you have, the closer the correlations are between what the crisis workers wrote versus what the children wrote and the youth wrote on their own perceptions of their mood. So basically, they're aligning. So the youth says, I'm distressed, and the ratings that the crisis workers rate on the HEDS-ED was correlated with that level of distress. Great, not bad. Then we looked at the correlations between the 1 hour assessment done with the cans and the corresponding items done on the HEDS-ED, which takes, much less time. And again, if you don't know nothing about statistics, but you can read stars, you can see that the higher the scores on the cans, the higher the scores on the HEDS-ED. So again, it was really correlated. But, that's the same person doing the same thing. So what we also looked at the scores. I forgot to put the star. Well, no, I didn't put the stars there. So we had someone, blindly, not that they were blind, but they observed and then they completed their own rating of the HEDS-ED, independent of what the crisis workers' HEDS-ED scores were. And these, I could tell you, were all significant to under 0.001, and that would translate to about 3 stars each. So a really close correlation. So, we can assess some risk. So the second thing we wanted to look at, I'm hitting things as I'm moving through. There we go. Can it facilitate clinical decision making? So now we're really going to put this thing to test. And what we did was we wanted to look at how well can physicians now, the actual, not just the crisis workers now, but the actual ED physicians, how well can they complete the HEDS-ED so that it can actually facilitate their decision making. So we looked at roughly 640 kids who came through our emerge department, mostly at around the age of 15, more boys and more girls than boys. And this is what we did. Remember that, the HEDS-ED? All we did was we took that piece of paper, it was a 1-sheet paper, and we stapled it to the child's chart. And we asked the physician, when you see that child, just please complete this measure. So there's no training. So we didn't teach them how to do the HEDS-ED. We didn't have, any training videos on how to interview kids or youth. And these are pediatric physicians, so that you have to know, they know a little bit about mental health. They actually know quite a bit about mental health, but they know nothing about the HEDS-ED, other than that's all we did. And at the same time, roughly 40% of those kids are also seen by our crisis workers. So we wanted to look at, did the scores on the HEDS-ED predict psychiatric admissions or discharge to the community? So depending on the score, what happened to those kids? So the first thing I want to show you, these are the correlations between the emergency physician scores on the HEDS-ED and the crisis worker scores on the HEDS-ED. Remember, there was a subsample of kids that the crisis workers had seen that were also seen by the emergency physicians. The crisis workers didn't know how, the scores of the emergency physicians, so they were doing them independently. And again, if you take a look at the stars, between the correlation between crisis workers and ED physicians, they're all pretty correlated. Again, this is pretty good, right? There's no training, there's nothing. All it is a sheet of paper stapled to the front of the chart. And it's able to predict the level of distress. The other thing we found was that for the physicians, the higher the score on the HEDS-ED, the more likely that there would be a psychiatric consultation. And the higher the score in the HEDS-ED, the more likely they would be admitted. And if you looked at it from each score, these are kind of like hit you between the eyes, data, right? So this is the total score in the HEDS-ED, which is basic. Remember the 0, 1, 2, 0, 1, 2. If you just count those, 1 plus 1 plus 2 plus 3, these are the total scores. The higher the score on the HEDS-ED, the more likely that there would be a psychiatric, consultation. So the emergency physician would ask the psychiatrist or the resident to come down and have a more in-depth assessment, and the more likely that the child would be admitted to hospital. It's not perfect, right? Because there's some kids that may not be distressed that still need to be admitted, and some kids that still need a consultation. But clearly, you can see how the higher the score, the more likely they're going to get. They're making, the decisions make sense with the score in terms of the level of clinical need. So, the tool was pretty good at assessing risk, was pretty good at making some decisions. But lastly, the question was, how well did it do in terms of determining next step care? This was a study that was being done in IWK, which is the Children's Hospital in Halifax. And Sharon Clark, who's the lead on this project, and actually Bill and Kathy Pager, who is our chair and our chief of psychiatry, was working at the IWK during this time. And Sharon Clark contacted us. She had heard about this tool that we were developing and asked, can we use that tool for all kids that get referred to our mental health program to determine, based on their scores, or to help us determine what type of care the child should access. So in addition to using their navigators or their intake workers, part of what they also did was use this tool. And essentially what they found was that the higher the score, the more likely that they required more intensive services. So kids with really low scores didn't require intensive services in the hospital, but they sent them back to the community. Whereas the kids that score the highest are the ones that required the most level of care, the ones that required either the highly specialized services, as well as the kids who were presenting with concurrent disorders, which are the ones that Gail was talking about earlier, both mental health and substance and addiction challenges. So it predicted the type of care that they would need. So great. So now we knew that we had a tool that was able to assess risk, that was able to help clinical decision making, and would also help in terms of, decisions in terms of what type of care the child should be able to receive. So the next question is, and we all know this is where we always fall apart. And there's lots of these examples where we have these great discoveries, we have these great tools, and actually very few people use them. So it doesn't translate to practice. So how do we get the news out? How do we let people know about this tool? How do we get it used in the community? So through what couple things have happened since. So this is in Ontario, the HEADS-ED is now part of a provincial health service pathway. So when we're doing a pilot here at CHEO and at there's a Winchester and Cornwall, where they developed a clinical pathway that helps physicians then address the mental health needs as part of all kids accessing services. But the other thing it also did was it also helped. It also linked it to our community-based services. So if a child presented to our Emerge, for example, it wasn't just asking, the pathway didn't just go from hospital to hospital. The pathway also directed them to services in the community. So when they discharged them to the community based on the pathway, it would say, well, this child would be best serviced at YSB, or this child would be best serviced at Crossroads or Readerwood, depending on the type of service. So it's being used in Ontario as part of our clinical pathways. Just recently, we found out that the HEADS-ED has now been recommended by the U.S. Department of Health and Human Services within their own pathway. So you can't really see it, but that's the HEADS-ED. So it's part of their pathway. In Ottawa, if a child is seen at a school by one of our mental health crisis workers in the school, they complete the HEADS-ED, they contact our emergency department, our crisis workers, and they have a way of communicating the score so that when the child comes to the emergency department, they've already used the same tool. So it's kind of like a bit of, getting, the vitals. If the ambulance shows up, they get a vital. By the time they come to the emergency, you already know a little bit about that youth. In Toronto, all kids that are referred for mental health services in the community As part of their triage, they complete the HEDS ED. So the other project we're working on currently is with our family physicians. I mentioned that earlier. If it works with our emergency, docs, it should also be able to hopefully work with our primary care docs. So we actually have a study that is being conducted at this point, and we're looking at 6 different sites in Ontario, including up north in Algoma, in Windsor, in the Belleville area, in the London area, in the Cornwall area, and in Toronto, where we're looking at different pathways to help family health physicians or family health teams and and family physicians determine where to how to best triage the child's needs. So whether they score high, they send them to the Emerge, or whether they score low, they send them to the community agency. The community agency then follows up with the provider. So again, there's a linkage of services there. So the family doc sees them. They either go to the Emerge if the need is high, and if the need is low, they go to the community-based services, and both then connect back to the family physician so that they know where the child is in terms of their level of care. We've also developed a website, both a regional one and a more generic one for folks to use. And I thought I would just take a quick second just to sort of show you what that looks like. So we have electronic versions of the tool now that are embedded within our electronic medical records. So at CHEO, we use Epic, for example. And then sometimes folks use this link. So just to sort of show you what it would look like. So imagine I saw a child who was 14, and it was an English-speaking, and it was a female, and not on the spectrum. And let's just say, for example, they lived in, I don't know, let's go with Stormont Dundas. Anyone here from Stormont Dundas, Glengarry? Okay. That's the Cornwall area. So imagine, the physician is using the digital, version of it. So they find out that there's things are good at home. The child is experiencing some difficulties at school. Has been spending less time with their friends. Hasn't been using drugs, but there's been some suicidal thoughts. Is a little anxious and is not on a wait list, or they're not currently getting any services. If they're not sure what to ask by any chance, they can always hit the sample questions, and it gives them, some options there. And if they want to write a note, they can write a note. And then they've read it and they submit. And it basically shows them where the child scores. A score of 8 or above recommends sending the child to the emergency department. A score of 2 on suicidality recommends sending the child to the emergency department. And you can see this child scored a 5, so there's concerns, but not enough to send to the Emerge. And then what it tells the physician then are what services are available in the community, and they can pick which one they want to send them to. So in Cornwall, they could send them to the Cornwall Community Child and Youth Mental Health Services. That's their equivalent to our YSB. It's a day treatment, and we always give them the details for the crisis line, the kids' help phone line. They can then print the results for their file, or they can email the results and that they can give to the parents and the caregiver, so they can do something like this, and it shows them all, the information that they can take with them when they leave the emergency department, or if they're leaving their family physician's office. So the other thing is, I'm going to go back to this, is that the way the tool was published, and what we've done is we published under something called the Creative Commons. The Creative Commons means that essentially they are free to use the tool. There's no cost. They don't even have to contact us if they want to use the tool. I was at a meeting. So what happens is we don't really know who's using the tool. We only know that the folks have contacted us, and we get lots and lots of requests. Say, can we use your tool? How much does it cost? We get lots of calls from the U.S. and other places in which when we tell them it's free, they ask, are you serious? Is there a licensing fee? We know it's free. You can use it. You can use our website. It's free. We can help develop a website for you. It's free. So I was at a meeting a couple months ago. I'm not sure how many people here can read Italian. So it turns out, I was at this meeting and someone says, you know what, Mario? They're using it in Italy. So it's being used in Milan, it's being used in a few other cities up north, and they've taken it, so this is the Italian version of it. And you can see that the heads is La Famiglia, you know? So it doesn't really line up with H, but they've kept it, you know, very similar, right? So it's really quite, it was quite interesting. I contacted them and asked, can I come and give a talk? And I'm planning to head over there next year to share with them some of the work that we're doing here. So it was really kind of neat to see. So thank you for listening, and I think we've tried to leave some time for some Q&A.
And I will questions from the audience.
So I think there's a couple things. One is that our belief is that kids are will answer honestly because they are seeking help. So in the emergency department, we get lots of kids who are escorted by police, right? And they clearly aren't happy being there, but they also recognize that they're being escorted there because things aren't going well. And so we do, there is a bit of, you have to trust that the kids will be honest with you. Now, and Gail can, and Simon and Bill, it doesn't matter if it's the head ZD or something else, right? There's always going to be, some challenges, right? And so oftentimes, we also ask the parents, right? What is going on, right? And also try to, and that's part of the filling in the whole, filling in the, all the answers. We all, kids who are anxious and depressed almost always are, more forthcoming than kids who are presenting with, that are handcuffed.
Hi, I have a question actually, I think it's more for Dr. Gardner. With the data sets that you were using, it was limited to the emergency visits, emergency department visits. So I'm wondering if there's an appetite to expand that data set. I know you talked about big data, but expand that data set to like the school boards to get, because I'm curious about the gap of non-identified, the ones that don't present.
It's a great question. We were identifying the kids initially through emergency department visits, but we were following them up throughout any further contacts they had. So after they were seen in the emergency department, we had data on them wherever else in the healthcare system they showed up. But your question about the schools is entirely on point. Right now, the data systems for education and the healthcare system don't talk to each other. And so it's not really possible right now to put together a composite data set that would get all those sectors together. But many of us feel that the future, we could do that, perhaps. And certainly in some of our other work, we work as closely with people who are school mental health nurses. So you're absolutely right, that would be a great place to do. Just something for food for thought, though, is many people with privacy concerns would worry, I think, about putting together data from all different parts of life in one linked data set. I think that we have to go into this kind of thing slowly and carefully with really careful attention to people's privacy concerns to get there. So, great idea, but it's not really feasible for us yet.
You know, even the privacy that you're talking about, Bill, how challenging it is to access some of the data from, you know, ICAS, right? If they're very stringent.
Oh yeah, we don't just get to walk in and look in, and I didn't.
Folks to know.
Right, just for everybody to know, I don't know anything about any of your healthcare because it's all shielded. The identifiers are shielded from me. So.
I was wondering if you've seen an increase in visits because of the increase in addiction to gaming. It seems to be
Is that a question for me?
Whichever.
But I think all of us probably.
Whichever one of you.
I'll start. I can't pick that up in our data. The emergency department isn't going to be able to link that way. We don't have an ability to do that. I certainly think that from other things I've looked at, though, there are kids out there who are spending 40 hours plus a week, 50 hours plus a week gaming. That's something you'd have to call an addictive behavior, first of all, and second, it would really interfere with a lot of the other developmental tasks that you're trying to accomplish at that period. So I think it's a matter of great concern. I don't know whether it's triggering emergency department visits.
Yeah, you are. I don't have my glasses. I hear your voice.
Always my voice, Mary.
So I just wanted to know.
glad you remembered your first visits to emergency at Chino when it was all brain disorder.
So my first study, my first job was in 1983, and Denise was actually the principal investigator. It was a study looking at the effectiveness of child life workers. Oh. So sorry about that. So that was Denise Alcock who just asked the question. And my first job was in 1983 at CHEO as a research student. I just finished my undergrad, and Denise was the director of the Child Life Program, and they were running a study looking at how well do child life, how well having a child life worker, does it help kids who present to the emergency departments with sutures in terms of easing their pain and anxiety? And she gave me my first job. Thank you, Denise. Here we are, how many years later? I'm answering questions. Earlier this week, we met with a group of folks from Korea who came to learn a little bit more about our child and youth mental health services. And with them, half the contingency was concerned with what? Gaming. And so they have a huge inpatient unit just dedicated to gaming. Gaming is a huge problem in Japan and Korea, and huge rates of insomnia and tremendous challenges. I don't know what our rates are for our inpatient unit. And Gail, you probably.
So at the Royal, we're just beginning to screen, I would say, in the last 15 months around that. And we've worked with our substance use and concurrent disorders program because they have a screening, and there is a screening now available on gaming or screen addictions. So you can find that fairly easily online. And when we see a youth who has it follows the addictive pattern of any substance behavior, and looks exactly, when you hear it, you can hear that it matches, could you have a marijuana addiction? Could you have a nicotine addiction? But we are using it now as part of a screening tool because it fits with a lot of the young people we're seeing, not so much inpatients as outpatients.
The reality too is that, Denise, the reality is that, when you present to the emerge department, we really want to keep our kids out of our inpatient units, right? And it's, the decision to admit is often based on imminent risk to self when it comes to harm. And I think we need to have more, what we're really missing is more specialized mental health services on an outpatient basis for children and youth and for families as well. And because I'm not sure, I'm a parent of 2 teen girls, and I hear it every morning from my own spouse telling me, Mario, we got to do something about our 12-year-old's use of her phone, right? Because, and it's a challenge for all of us, right?
I was just wondering if there's any research being done about young people self-diagnosing online, like they're so exposed to programming and videos and all kinds of information, and I wonder if maybe they think they have these issues going on, but it almost becomes embellished in their mind, and then when they go to see a professional, is the professional really able to distinguish the truth? Like the woman over here said, can you tell the truth? Because, I find maybe I don't see the same things as what the children are saying. I don't know.
So maybe I'll start with the clinical picture. I think that right now it would be unusual for us in our program to see anybody who hasn't researched something that we've told them online. Now that doesn't speak to the question that you're asking about research. The other thing I'll tell you is that we're often telling people, we're directing them very specifically to websites, because since we know they're going to look things up online anyway, we'd rather say use these websites which are more reputable and which are providing good information, other than some websites that are providing more misinformation. That's the clinical setting, but I don't know if either Dr. Gardner or Dr. Capelli can speak to the other thing. And I did have a comment after on the screens, but let's finish with this question.
The only, just put on my clinical hat now, and I'll just say that, I do get, I do get kids coming into, that I see that will say, oh, I think I'm on the spectrum, or I think I have, multiple personality disorder, or, lots of different things. And I don't get really, I don't get pulled into that. From my perspective, it's still about a child that is, really not coping well, and is really looking for help, and is basically telling me I need help. And so I don't get caught up in what self-diagnosis they're presenting with. I really kind of just peel that layer away, and we kind of just drill a bit lower. So it's really a clinical, it's a real clinical issue.
So if it's real from their perception, then you treat it as real.
Well, it's not, I'm not treating it if she tells me or he tells me, oh, I think I have multiple personality disorders. I'm not validating whether they have multiple personality disorder or not. What I'm really validating is that, you're not doing well.
It's a great question, and I think that there likely is a component of increased use of mental health services that comes from people who you might call the worried well, people who over medicalize the degree of some personal problem they're having that really doesn't have a underlying mental health disorder component to it. Having said that, the group of kids I'm interested in who are showing up in the emergency department with self-harm, the thrust of our big study there was that yeah, really, this is a marker for kids who are not going to do well in the next 5 years. I think there really is a component out there of kids who we're finding, who might not have been found before, who really have serious problems and they have real mental health needs. We need to do a lot of work on doing a better job of describing the distribution of problems out there, trying to sort out which ones are more and less serious. The message I want to say, though, is that among the kids who do have serious mental health concerns and problems with self-harm and such like, there's not enough care available for them. So that it's a mixed bag, and you're pointing to something real, but I try to tamp down people who sometimes go in the direction of, oh, it's just kids who are, just worried or being told they're mentally ill. There's maybe some of that, but then there's a lot of real need.
It's like a bandwagon thing. Well, my friend has anxiety, so I might have anxiety.
it's a great
my
question.
friend's on meds, so maybe I should get some meds. And it's like, oh, Mom, maybe I should go get some meds. And you're like, what? What are you talking
Well,
about?
and that's why
all
it's
these kids on meds.
No, sure, and it's a very valid question you're raising. It's why it's important to have psychologists and mental health and psychiatrists and mental health professionals who can really make a good judgment of who needs the services and who needs maybe counseling, maybe problems dealing with other sources of distress.
I'll say one last thing about this, and then I did want to make this other point around screens, that something I found out this summer that I found a little shocking. I think that for certainly all of the programs that we have at the Royal, and I can say this as clinical director because my job is to set the clinical vision for the program, and I know that that's true at our partner at CHEO, is that our emphasis when we're seeing youth is, in fact, as medical units, to make an appropriate diagnosis according to the best evidence and to treat conditions according to that evidence. Having said that, my experience in both places and what we really try to do is we will certainly use medication when it's indicated, but we do have a philosophy that we also want to give people skills and strategies and tools that they can use above medication. And so that's an emphasis that's really important to us. And we feel that the people coming back to emergency, you'll often see that they've had medication, but if they haven't had the skills, then they're not going to be able to get well. On the screens, I spent this summer reviewing children's books that I felt were important to read, and my blog is on youth mental health and addiction. And I wanted to reference a book that I saw, and it was called Lost Words, and it's really, it could be for anyone, but it's pitched so that it could be read by young children. And this book was written by a very well-known scholar from Britain at Cambridge, who's a world-famous naturalist, Robert Macfarlane. And this book, Lost Words, is about 40 words that were dropped from the Oxford Junior Dictionary as it came out with its new edition. And I'm going to say some of these words, and it was amazing to me that these words were dropped from the dictionary. Dandelion, otter, heron. Like, you can't walk in a field in summer, even in Britain, and not see dandelions. Herons, like, you can't, there isn't a lake in this country that doesn't have herons on the edge, and otters, again, an animal you see everywhere. Some of the words that are included that weren't before are words like attachment, words like blog. And for Macfarlane, it was an emphasis that one of the side effects of screens has been to move us away from a natural world. And there is significant evidence that for children who are developing, contact with the natural world is very important. And I think that, this is the risk of our children being in front of screens, is that it is easier than going for a walk with them. And certainly it's a busy time, but it's certainly worth looking at this. If you have the time, you can get it from the public library. And I did find it fairly shocking myself, and a real emphasis on what's happening because of screens in the world.
Thank you, everyone, for coming, and I'd like to thank the speakers for great talks and the audience for great questions. It was a great session. And if you have any feedback for us or any suggestions for next year's Brain Health Awareness Week, let us know. We have one more session tomorrow, and it's, I think, cracking the neural code, and it's about synaptic function and how the brain works. But if you have any feedback and suggestions for next year, just let us know. So the speakers will be out in the atrium, so please join us in the atrium. And also one last thank you to our team, Victoria, Natasha, and Candace. And please join us out for coffee and refreshments. Thanks a lot for coming.